Lung, presented by Dr. Mary Maish. Please welcome back Dr. Maish.
A couple of good questions came up, so I thought I would just try to remember a few of them. The first thing is, how many centimeters of a myotomy to performing achalasia? So it's generally 5 to 7 centimeters above the lower esophageal sphincter, and then most importantly, it's 2 centimeters onto the stomach. And somebody asked me how I perform that. I generally I perform the proximal myotomy with either harmonic or cautery scissors, and then I perform the distal with a hook cautery, which you probably wouldn't be asked on exam, but people were asking me that. Yep.
Any questions going to come up on endoscopic myotomies?
Right, that's a good question. So the question is anything going to come up on endoscopic myotomies? I doubt it, but there is a new technique called the POEM, or per-oral endoscopic myotomy, that is now being used for achalasia. It's an awesome technique. The only thing that is so basically what they do is they do an endoscopy, they poke a hole in the mucosa, they get into the submucosal plane, they go down to the distal esophagus and then cut the muscle fibers all the way down on top of the stomach. They, of course, can't do any anti-reflux. So there has been, so far, an increase of reflux-associated symptoms after the POEM. It's still, I don't think there's enough literature out on it yet to be on an exam. I mean, there is some literature coming, but there isn't quite enough out there yet. I don't think it's going to be asked, but it may be just, an option, so it's something to think about. Another question somebody asked me was, if you go in and you see that you have high-grade dysplasia, how do you know when it should go for surgery or when you should do endoscopic mucosal resection? So again, if it's a raised lesion and you can find it, you can go in and you can do EMR, and that's the gold standard. So if your specimen is clean, meaning all the margins are cleanly resected and the deep margin is resected as well, and you don't see any evidence of invasive adenocarcinoma, you don't need to do esophagectomy on those patients. The time that you're going to do an esophagectomy in the case of high-grade dysplasia is when you can't find it, when it's a flat lesion, and you have gone in and repeatedly been able to biopsy that and not been able to locate it enough to be able to actually do a mucosal resection. So those patients are going to still need surgery or esophagectomy for treatment of their high-grade dysplasia. The only other time would be is if you have super long segment Barrett's and you can't properly survey it. So in those patients that have high-grade dysplasia, even with a raised lesion, you're going to want to go ahead and just resect their esophagus because, you can maybe treat the location of the raised high-grade dysplasia, but it's very difficult to treat like 10 centimeters of ongoing Barrett's esophagus and properly survey that. And then in the setting of somebody who already has high-grade dysplasia, go ahead and just take those people to the operating room and resect them. Let's see, there was another question about...
Just going along with that, when do you decide to do ablation? You said you can do ablation in the high grade, and you said in this right now, mucosal resection. So when do you decide to do what, or in the exam, do they ask both?
They're not likely to ask both. If you have a raised lesion, you're going to go ahead and do mucosal resection on that, endoscopic resection. And then you might use ablation to touch up the edges if you have ongoing Barrett's in that same area. Generally speaking, you're not going to treat high-grade dysplasia with ablation as a first-line treatment. If you can see it, you're going to go ahead and treat it with endoscopic resection. If you can't see it and you don't have long segment Barrett's, you might try to treat it with RFA. But I don't think you're going to get asked. That's just sort of too subtle of a gray zone right now. Let's see, there was one other question I can't remember, but if it comes to me, I'll save it for the end and repeat it. So with a couple things that came up. Okay, so we're going to move on to lung. Most of what we're going to talk about in lung is going to be lung cancer. I have tried to put together some pearls. There's always a lot of questions about lung. I don't know really why, but anyway, a lot of things we kind of don't see, but are going to be there. And the staging system for lung cancer is really challenging. So I'm going to try to help you know the things that are really important so that you can just debride all the rest of it, because it's just this horribly complicated system that even I can barely remember. So, even though I treat it every day. So hopefully we'll distill things down to just a few really important concepts here. We're going to talk about some benign disorders, lung cancers, briefly on some paraneoplastic syndromes, because I always love to ask about that. And then we're going to go on to talk about these pearls. The first question is, a patient presenting with a first-time spontaneous pneumothorax should be taken to the operating room if they meet which of the following criteria? A, planning a trip to a remote part of the world. B, if they're immunosuppressed. C, if they're over the age of 70. Or D, if they're flying for more than 2 hours. Right, the correct answer is A, planning a trip to a remote part of the world. Those are the patients that you are going to recommend to go ahead and get their spontaneous pneumothorax treated right away. Generally speaking, the first episode is going to be a chest tube. Now, patients that then return, you're going to counsel them and say they have about a 25% chance of returning after their first episode. But that is not true if they have Bleb disease. And so we're going to talk about Bleb disease next. But in the first episode, if you suspect somebody has Bleb disease, you're going to recommend treatment. So these are really patients presenting with primary spontaneous pneumothorax that have no underlying etiology. The tall, lanky, late teen, early 20-year-old male that has that spontaneous pneumothorax. Going to be treated with a chest tube, and 25% of the time they're going to return, but 75% of the time they're not going to. But if you have an etiology for that primary spontaneous pneumothorax, that's different. So we'll talk about that later. The second episode then, when that tall, lanky, late teenager comes back to you, then you're going to want to recommend surgery. We can do this all videoscopically through one single little incision. We just go ahead, collapse the lung, which is already partially collapsed, blast the talc in there, and sometimes perform an additional mechanical pleurodesis. So that wouldn't be necessary in most patients, but in some patients that have already diminished lung volume, so in patients that have COPD, for an example, where trying to get that lung to re-expand to fill the chest cavity might be a little bit challenging. You're probably going to try a little mechanical abrasion as well, just to give it that extra oomph to try to get that lung to stick up. So the exceptions to all of this would be in the first episode, if somebody is going to join the Peace Corps, then you just go ahead and do their pleurodesis right away so that they don't come back. Or anybody who's had a first episode on the contralateral side. So let's say you have this 19-year-old boy, he comes, he's had, his left lung has already been down, and now he's coming with the right lung. You're going to recommend, go ahead and get your right lung fixed, because the last thing you want them to do is present with a bilateral spontaneous. It's really rare, but not unrecorded. So you're going to want to try to fix one side so that they have, some comfort zone there. This is different than bullous disease. Many patients, I would say at least 50% of patients presenting outside of that classic young male, tall, lanky habitus, body habitus, are going to have bullous disease. So how do you know? First of all, what is it? Well, it's enlargement of the alveoli from chronic obstructive disease. So it can be a genetic predisposition, so you might find it in people who absolutely have never smoked and not been exposed to noxious substances that can cause the development of COPD, and also most often due to smoking or using of aggressive tobacco products. But these patients, when you put the chest tube in, you may see some re-expansion of the lung or near all re-expansion of the lung, but you're going to see an air leak. And that's completely different than you see in a spontaneous pneumothorax from no etiology. So you put that chest tube in and you've got an air leak, you've got a bullous. So you have to treat that differently. That's not the true primary spontaneous pneumothorax. So these patients need to go to the operating room. Preoperatively, you want to get a CT scan so that you can confirm that you have a bullous on that side, but you know what, it's collapsed, so you're not going to see it anymore, So a lot of times you know, the pulmonologist will tell me, oh, no, there's no bullous disease on that side. It's on the other side. Oh, yeah, okay, well, whatever. You know it's there. It's just you can't see it because it's collapsed. If you see it on the other side, it even confirms even more that you've got bullous disease on the side of concern. So mostly it's to confirm that you have disease on the other side, and also to then stage treatment for the future. It also kind of gives you an idea of how somebody might tolerate one lung ventilation, because you know, if they've got a lot of bullous disease in their contralateral lung, they may not tolerate one lung ventilation very well. So you're going to take these patients to the operating room. You're going to do a VATS approach. So they're going to require, lung isolation anesthesia. And then you're going to address the bullous first. So you have to find the bullous and then do a resection. So this is where you have to be aggressive, okay? If you have a small bullous, you just do a wedge resection. No big deal. If you have a big bullous and it's in the central part of your lobe, you have to do a lobectomy. So, I mean, this is where, you know, it's going to be the classic question where they're going to be like, oh, you know, the bullous is, you know, confined to the right upper lobe and, you know, very central and comes, you know, within, you know, 1 centimeter of the mainstem bronchus. And then they're going to say, oh, what do you want to do? You know, drain it, wedge resection, pigtail catheter. Okay, no, they need a lobectomy. And it seems like it's drastic, but, you know, don't be afraid. That's what they need. Even sometimes we have to do pneumonectomies. It's very rare, and I doubt you're going to get that question. But, you know, think about it. You got to resect the entire bullous. Otherwise, it's going to continue to leak, and it'll never get better. And again, then thinking about stage contralateral resection, it has to be a part of your discussion with the patient before they leave the hospital, because the chances that they're going to recur are very, very high. So they're likely to have a recurrence on the other side before, you know, they even come back for their 3-month post-op visit. So might as well stage them, get them out of the way. You can stage them, you know, even within a couple of days if you want to do it the same hospitalization, or certainly within a couple of weeks. Question: under what circumstances would a patient presenting with a TB effusion have a chest tube placed for adequate drainage? A, underlying lung cancer. B, never place a chest tube in this instance. C, if it is greater than 350 cc's. Or D, if it is bloody. The answer is B, never place a chest tube in this instance. So it is sometimes very difficult to convince people of this, but if you put a chest tube in somebody that has TB, they're going to end up with a big, gigantic mess. It's going to be a huge empyema, very difficult to treat, and something that will almost never go away, and you're going to really regret it. And so it's very critical if you get a test question about a patient that has a pleural effusion, if they're leading you in any direction at all, you know, like maybe they were, you know, foreigners that have come for traveling in this country, or, you know, they've had a history of TB exposure or positive PPD or anything that triggers TB, just, you know, tap that effusion. Don't drain it. Just tap it and figure out what it is, and you'll be safe. So that brings us into fungal infections and abscesses. We see a lot of this out in California. You see a different mix of it here in the Midwest, and then, of course, in different parts of the world, different kinds of infections are, you know, prominent. But the principles sort of stay the same. Most often, before you take anybody to the operating room for a fungal infection, they are going to need to be aggressively treated with antifungals, and then often a change in the treatment of antifungals. So generally speaking, by the time somebody comes to see me, that's already happened. But on an exam, if they're trying to get you to take a patient to the operating room to treat fungal disease in some regard, they need to have been treated primarily with antifungals, and then secondarily maybe with a second-line antifungal treatment for a fungus that may, you know, be somewhat resistant. That's true of all of them, whether you're talking about TB or Aspergillus. There are only a couple exceptions to that, and that is when there's an abscess that forms, which of course is not likely to respond at all. But there are some things about the abscess that can also push you into going to the operating room. So one would be a thick-walled cavity, right? So the antibiotics cannot penetrate a thick-walled cavity, or somebody who has a contained abscess where access by percutaneous drainage is not going to be possible. Okay, so those two situations where the disease has sort of coalesced into an abscess, then you can think about taking it out surgically. The third instance is with aspergillus, which is not the same as an aspergilloma, right? So aspergillus is a diffuse disease that generally affects more than one lobe. And aspergilloma is a small little fungus ball. It's not an abscess. It's just a small little fungus ball where the fungus is just in there growing and living happily. And those patients, generally speaking, don't get disseminated disease. But over time, it can lead to disseminated disease if it's not removed. And so that's why you take it out. So again, fungal disease is treated with antifungals, and then second-line antifungals, and then lastly, going to the operating room to remove an abscess if there doesn't seem to be any way for that abscess to be drained, or for an aspergilloma, which is always treated with surgery. And what were you going to do? You're going to treat it either with wedge resection. I mean, if you can get a nice margin of tissue around the diseased area, the abscess or the aspergilloma, you don't need to do a lobectomy. If you can't, then you need to progress to do a lobectomy. So don't be afraid to do a lobectomy. If you need to do it, that's the only way to cure these people. And you want to make sure that you get as much of that disease out as possible. Otherwise, they're just going to continue to recur. When you're looking at an abscess, and if you see an air fluid level on the CT scan, if they give you a little diagram with an air fluid level, these patients, that means they're being internally drained, right? There's a connection to the bronchus. Those people can expectorate all of that pus. So generally speaking, they don't need to go to the operating room. You know, maybe if the cavity is very big or the patient's really sick and they just can't seem to expectorate at all, but with good IV antibiotic treatment, they should be able to expectorate all of that pus, and it does not need to be drained or surgically removed. One of the more common reasons why you may see an abscess in the lung is due to a pulmonary sequestration. I mean, we don't see abscesses very often, and we see sequestrations even less. But it's not uncommon, on an exam when they're trying to sort of test your knowledge of all these sort of not very common things, to see something about a sequestration in relationship to an infection. So the sequestration is where a cystic or a solid, it can either be cystic or solid. It's composed of this non-functioning primitive tissue. And it generally it no longer has a true connection to the tracheobronchial tree. And it often has its own sort of erroneous blood supply directly from the systemic circulation, not from the pulmonary circulation. So you've got two types. One are the intrapulmonary, which is just surrounded by normal lung tissue, and then the extrapulmonary, where it looks like you've got an extra little lobe. And the reason that we remove these are only because they become infected. It otherwise doesn't really matter, but because their drainage and their arterial supply is not normal, it often, these areas of the lung, or these sequestered areas, often don't have the same ability to drain, and so they can get infected. So if you randomly happen to find somebody who has a pulmonary sequestration, you recommend surgery to prevent infections. But more commonly, somebody is going to prevent with a pulmonary infection, then they're going to get a CT scan that demonstrates they have a sequestration, and then you're going to go ahead and recommend surgery. So you can fiddle around with, drainage and antibiotics and all that, but it's not likely ever going to work in somebody who has a sequestration. So that's the only other thing to think about in a pulmonary infection question is, do they have a sequestration? And if they do, forget about antifungal treatment, forget about drainage, just take them right to the operating room to take it out. Question: what size solitary pulmonary nodule requires follow-up? A, all solitary pulmonary nodules should be followed up. B, an SPN less than 6 millimeters should be followed every 6 months. C, an SPN greater than 1 centimeter should be reevaluated in a year. Or D, an SPN less than 4 millimeters should be reevaluated in a year. So we're going to talk a little bit about, I'm going to give you a chart. It's become sort of like, the nouveau thing to evaluate these SPNs. And the reason is because Medicare just approved reimbursement for CT scans on patients who fall into a high-risk category. So that would be patients with previous respiratory infections, recurrent respiratory infections, use of tobacco products, or a history of pulmonary disease or lung cancer. So these patients fall into this category of getting CT scans and for evaluating for lung cancer, and therefore now we have this huge new area of evaluating solitary pulmonary nodules, which is coming into the surgical arena. So that's the only reason why you need to know about it. We've had this for a very long time, but because now we have all this extra reimbursement, we see a lot more patients with it, and so you have to know when you need to repeat a CT scan. So the first thing on a question is find out in your head, is this patient a low-risk patient or a high-risk patient? And once you determine that, then you can have this algorithm in your head. And I always tell people, just remember the low and the high, and in the middle, kind of figure it out. You know, it's kind of like one of those things, you can just approximate it. More than likely, you're going to get it right. So the key number in this one is 4 millimeters. If you're bigger than 4 millimeters, you're going to need some kind of follow-up. In this case, it's going to be, you know, in a high-risk patient, it's going to be in a year, you're going to need to go ahead and take another look. And then in the middle, you're going to have, you know, you between your 4 and your 6, and your 6 and your 8. You can kind of, you know, change that from 12 months to 6 months, and 6 months down to 3 months. But it's greater than 8 millimeters when you're going to need to get a biopsy. That's the board answer. In reality, what do? We take a look at these small nodules. We think about their other comorbidities and whether they have a history of cancer. We get PET scans on them to see if they light up. And then we go ahead and we decide whether or not they're going to be resected. But that's not really what the board answer is going to be. The solitary pulmonary nodule clinics that follow these criteria, this is the exact criteria that they follow. And, you know, if you get a question on it, if you can commit this to memory, you're going to be good to go. There will probably be something. It's such a hot topic right now, so I think it's very likely there will be something from here. So remember the number of 4, and then greater than 8. If you remember those two things, I think you'll be good to go. So that segues nicely into lung cancer, because of course the more you survey, the more you find. And lung cancer is it's this complicated staging system, and so if you're going to pay attention to anything, this is the 2 minutes to pay attention to, because I'm going to help you understand it so that you never have to think about it again. Under what conditions is mediastinoscopy recommended to stage patients with lung cancer? A, all cases should be staged with mediastinoscopy. B, patients without cardiopulmonary illness. C, to rule out metastatic disease. Or D, any patient with a PET-positive mediastinum. So the correct answer is D, any patient with a PET-positive mediastinum. We're gonna talk about that, but the key thing here is to remember that not everybody is going to absolutely have to have mediastinoscopy. Okay, so but there are some people that will, and this is the patient, the one who has this PET-avid mediastinum. Next question: what differentiates a stage 2 from a stage 3A? A, mediastinal lymph node involvement. B, invasion of the pleura. C, hilar lymph node involvement. D, pleural effusion. And for those of you that don't do thoracic, you're probably looking at this going, ugh. Okay, and the answer is A, mediastinal lymph node involvement. But I'm going to help you, so you never have to think about it. Okay, let's talk briefly on the types. The reason why I talk about the types here is because, we all know there's adenocarcinomas and sort of the profile of the person who, smokes. And the peripheral tumors tend to be adenocarcinomas. They are not the patients presenting with hemoptysis. The hemoptysis patients are the squamous cell cancers and the small cell cancers, okay? But the key is this category of bronchoalveolar carcinomas, or now being classified as carcinoma in situ. These are diffuse lesions. They often present with this haziness in a lobe with no discrete lesion that over time might coalesce into a single lesion, small, very small lesion that becomes a single site of invasion. So the big controversy is, how do you treat this? Because these patients do not respond to chemotherapy because it's it's in situ, right? There's very little neurovascular invasion, if any, right? I mean, it's so diffuse, it's really hard to know. But the key is that it comes up because it's very commonly seen in women who are non-smokers. Okay, we don't know why, but anyway, it's sort of the buzzwords and the links that you're going to find on the exam. This bronchoalveolar carcinoma associated with women and non-smokers. How do you treat it? Generally speaking, we try to treat it along the same lines as all the rest of the lung cancers, but because it almost never has nodal involvement and takes quite a long time to coalesce into an actual lesion, it's not always clear cut. The workup generally begins with a CT scan that is obtained because of an abnormal chest x-ray or maybe a symptom presenting with cough, then proceeds with a mediastinoscopy. There are two schools of thought on mediastinoscopy. One is get it on every patient, and other is only get it if it's a PET positive. There is no literature to support one direction or the other, except for in the PET positive patient. That patient is always going to need a mediastinoscopy to confirm that the PET-avid lesions are cancer, right? Because in fungal disease, we commonly get PET-avid lesions in our mediastinum. So whether you decide to do it every time or not every time, it doesn't really matter. The important thing is to remember that if it is PET-avid, everybody agrees that that lesion needs to be biopsied or that lymph node needs to be biopsied before you can adequately stage a patient. EBUS and EUS are also used to try to evaluate the mediastinum, especially in patients who have had previous mediastinoscopy and are all scarred in. Might be a difficult redo mediastinoscopy. EBUS is endobronchial ultrasound and EUS is endoscopic ultrasound. Both of them mostly have limitations because you're using fine needle aspiration and, you know, not the best in terms of having a reliable diagnosis. And then finally, a transthoracic biopsy is generally done because you can get good core needle biopsies of the lesion itself. If that's not possible, a transbronchial biopsy, often directed with what we have, what's called SuperD. It's a CT-guided program that allows you to see exactly where the mass lesion is before you stick a needle into it. But again, the transbronchial is limited by the size of the needle, so not the best. Transthoracic, very good because you can get core needles. We look very closely at the patient's pulmonary performance. Again, a little bit of tedious work to remember, but if you can remember 40-60, anybody with with FEV1 or FVC of 60% or better, you could do up to a pneumonectomy on them, and anything below 40, you're going to recommend against a pneumonectomy, but they might still be able to tolerate a lobectomy. And in between, you get a VQ scan to see if the diseased part of the lung that's coming out contributes at all to the overall function, because if it doesn't, then you're going to end up with almost exactly the same PFTs after the surgery, right? You're going to see that if most of the perfusion and ventilation defect is in the same lobe, then the overall function shouldn't change post-surgery. We also do sometimes a pulmonary exercise test, although honestly, you know, what I do is walk them up and down a bunch of stairs and see how they do. It works just the same as getting a pulmonary exercise test, which is not done very often. Then we want to take a look at their T stage and their end stage and see if we can best approximate where they're at. So the T stage is very, very complicated, but all you need to remember is for lesions that are in the T1 category is the number 3, so 3 centimeters or less, and they're still a T1, and that's going to help stage them later. So all the rest of the T stages are based on the tumor getting bigger or the tumor getting more central. Okay, so you got to kind of think about that in lung cancer. So as the tumor gets bigger, the T stage is going to go up, but also as it gets closer to the carina, it's going to go up. So as it starts to get more central, of course, the lung tissue beyond the tumor is going to start to be affected, right? So in a stage T2, you're going to start to see some pneumonitis, right? Because this obstruction of the tumor more centrally, the more central it is, the more pneumonitis you're going to get, okay? And also starts to get closer to the main stem bronchus, but still greater than 2 centimeters away from the carina. But now you can see in T3, okay, the tumor is getting bigger. That's kind of easy. You don't need to remember that number because remember, it's just the number 3 that you have to remember for a T1 lesion, the number 3. But as we get closer to the carina, now we're getting within 2 centimeters. Now that lung is going to be more obstructed and you're more likely to get pneumonia, right, than pneumonitis. So now that bumps you into T3. And also the tumor is getting big enough that it starts to invade things. But all things that we can take out. So it could invade the pleura, it could invade the diaphragm, it could invade the pericardium, but these are all structures that you can take out. And this is in contradistinction to stage or T4 lesions, which are now invading things that you can't take out. Okay, so it's not so important to remember the size. It's not also so important to remember the location, but it's important to just remember a few of the cutoffs. So 3 centimeters or less for a T1. The more central you get and towards the carina, you're going to start getting pneumonia or pneumonitis, and that's going to bump you up in the stage. Or you're going to have an invasion of things that you can't take out, and that's going to make you a T4. Okay, then we need to think about the end stage. Okay, to think about the end stage, you need to understand the anatomy of the mediastinum. The lungs are completely covered by the pleura, or the pleural envelope, and outside of the pleural envelope is the mediastinum. Okay, so that's why even though the mediastinum, when you look at it, you know, the anatomy, you think, well, why? You know, how could the mediastinum have such a dramatic effect on stage? It's because it's actually into a different space. It's a completely different space. So anything in the hilum or in the lungs itself are all enveloped within this pleural envelope, right? So they're kind of protected by the pleura. But the minute the lymph node or the disease starts to bust outside of that pleural envelope into the mediastinum, it bumps up to an N2. And N2 is the beginning of stage 3 disease. I mean, it's dramatic in terms of the survival. You know, stage 3 patients generally have like a, 15 to 20% 5-year survival. It's dismal. As opposed to stage 2 patients who can have disease in the hilar lymph nodes, but if it's contained to that pleural envelope, they can still have 50, 60% 5-year survival. So it's a dramatic difference because the mediastinum is basically like having a met to the brain or somewhere else. It's closer to the lung, but it's completely outside of this protective barrier. So you need to really think about that when you're looking at lung disease. And then N3 is where the disease is not only now outside of the pleural envelope, but it's also gone to the other side or it's up above the clavicles. So yet another body cavity. So here you are. Here's the complicated staging map, which you do not need to know, except for trying to remember the number 3. If you remember the number 3, then you'll know that you're at a T1 lesion, and that's going to help you with the stage. And then remember that mediastinal lymph nodes are outside of that pleural envelope, and that's going to put you into a stage 3. So 3 kind of gets it for you for most of all the questions you get on lung cancer. There will be others, I'm sure, but if you can remember those 3, the number 3, it's going to help you dramatically. So here you go. We label these lymph nodes according to location and according to number, okay? The numbers are probably the easiest to remember in the sense that the mediastinal lymph nodes are the low numbers, and the hilar lymph nodes and everything within that pleura begin with the double digit. So, I mean, I always sort of remembered when I was learning it, 2 pleura, double digit, no pleura, single digit, right? All the others are just locations, which you probably don't need to know, but, they might say something like paratracheal. That's kind of easy to know. Paratracheal, it's going to be in the mediastinum. So you can kind of briefly look at these things, but again, the most important thing is to remember that these mediastinal lymph nodes are outside of the pleural envelope and designate a stage 3 tumor. Here's just a map that we use that you have for, just reference in the future. M stage is contralateral lung disease, pleural nodules, so anything that's growing into the rib cage itself, so plaquing or pleural nodules, and then a malignant pleural effusion. So you might see somebody for lung cancer that has only like a 3 centimeter lesion, so it wouldn't seem like it would be all that advanced, but then they have, happens to be on the surface of the pleura, they have an effusion. You need to tap that effusion first and make sure that the cells aren't already spilling into the pleural cavity, because once they do, you can't contain the disease. You can take out all the tissue you want. It's kind of like having mesothelioma. you can take out all the tissue you want, but there's really nothing you can do to really contain the disease. So a pleural effusion in the face of known lung cancer absolutely has to be tapped before you make any treatment decisions. And then finally, M1B is distant disease, which of course, like with anything else, is palliation only. So when you look at the staging system here, you can see that T1 lesions, the very first, that 3 centimeter or less, only is for a stage 1A. And that's the only time where surgery alone is going to be recommended. Okay, that's why it's important to remember. And then you can see that stage 3A disease is the first time that you have N2 disease positive, right? Those are the lymph nodes in the mediastinum that are outside that pleural envelope. And that's going to be the first time that you definitively can recommend neoadjuvant chemo or chemoradiotherapy, okay? And all that area in between is a gray zone. So you don't need to know that because it's a gray zone. You just need to know that stage 1A is the only one that you can definitively recommend surgery. And stage 3A is when you first can definitively recommend neoadjuvant therapy. Everything else is a gray zone, and you don't need to know it. Stage 3B and stage 4 are non-surgical. I don't know why I included this, but I think just to show you the dramatic differences in survival. Okay, so here we go. The treatment. Stage 1, surgery alone. Stage 2, surgery with the possibility of adjuvant chemo. Stage 3A, definitely neoadjuvant therapy, followed by surgery. And then stage 3B and stage 4 are non-operative. That's why it's critical for you to remember those 3s, 3 centimeters or less for the stage 1A, stage 1, the 1A tumor, or stage 3 tumors with those mediastinal lymph nodes in the N2 position. Complications from non-surgical treatment are hemoptysis. You know, patients can, with these central squamous and small cell tumors, can have pretty dramatic hemoptysis. And you can also have intraparenchymal bleeding as well. Infection from obstructive pneumonia. Commonly, patients present with pneumonia for the first time, and then they're found to have a lung tumor. And then, of course, DVT and PE, just like any other cancers. Before we move on to paraneoplastic syndromes, I wanted to just mention one thing about the treatment of small cell lung cancer. Small cell lung cancer is on this continuum of these neuroendocrine tumors. And neuroendocrine tumors are complex in terms of the way they're going to be treated. Certainly nothing that you're going to be asked about. But small cell might be something that you see. And the reason is because we used to treat small cell tumors just like all other lung cancers, you know, along the stage of resection versus neoadjuvant therapy versus no surgery. But then small cell was considered a neoplastic, a neuroendocrine tumor that would be better treated by sort of like lymphoma with all chemotherapy, except for in one case, and that's a stage 1A tumor. So again, a small cell tumor that's 3 centimeters or less and has no lymph node disease can be treated with lobectomy with equal outcomes to chemotherapy. So it's an alternative, an equal alternative. It's neither better nor worse. It's an equal alternative to chemotherapy alone, okay? But that's only for these stage 1 or T1A tumors for small cell lung cancer. Everybody else, it's chemotherapy, okay? But that is one area where it's commonly adopted and might be something that you could see. Paraneoplastic syndromes we almost never see, but I'm sure you're going to see one. They basically kind of come down to either you're going to have these, Cushingoid, endocrinologic type things, or you're going to have these immunologic problems that are neurogenic in origin. So the small cell tumors are most commonly associated with these things. We do occasionally see adenocarcinomas that have a mixed pathology, and they will then present with some of these paraneoplastic syndromes, but it's pretty uncommon. Cushing's, SIADH, hypercalcemia are the most common. The carcinoids are just like anywhere else in the body. They can present with the carcinoid flushing and the changes in the fluctuation of the blood pressure. And again, these myasthenic type things are much more common with small cell tumors. But occasionally the dermatomyositis you can see with squamous cells. So, just be aware that they're out there. Okay, before we move on to the pearls, I want to give you some information on mediastinal tumors. It doesn't fit into lung per se, but it is kind of a chest thing, and I think that it's something that's helpful, and I always give it, and then people give me feedback that, oh yeah, there was a couple questions, so I think it's probably reasonable to know. We basically subdivide mediastinal tumors into anterior, middle, and posterior mediastinal tumors. And you don't need to know the cutoffs and anatomic cutoffs for that. But in the anterior compartment, it's the 4 T's. So it's the teratoma, the thyroid tumor, the terrible lymphoma, and the thymoma. Okay. All comers speaking, lymphoma is the most common of all mediastinal tumors. But in the anterior compartment specifically, thymomas are the most common. So how do you treat a thymoma? Okay. The classification of thymomas is complicated because, it's not very well defined, first of all, and it changes about every 20 years or so. So I wouldn't worry so much about the classification, but most people presenting with a thymoma are going to have one of 2 scenarios. One is invasion or no invasion. There's not going to be lymph nodes. You don't have to worry about any of that. If you know preoperatively that you have an invasion, then those patients are going to get neoadjuvant chemotherapy. Then they're going to get resected. And then they're going to get radiation to follow, because it's very hard to totally resect thymomas and control the local disease all surgically. So oftentimes there's little areas where you might have to leave smidgens of it here and there behind. You think you get it all, but you can't always say for sure. So anybody that preoperatively has invasion into like the lung or the pericardium, you're going to give neoadjuvant chemotherapy followed by surgery, followed by radiation. But the problem is that most preoperative techniques we have are not very good at evaluating invasion. MRI is not bad, but it's still not perfect. So most of the time we encounter invasion at the time of surgery sort of unexpectedly. So if that happens, you go ahead and you do the resection, because of course you don't know, right? So you're going in, oh, by the way, there's invasion into the lung. You take out part of the lung, you take out part of the pericardium, and then you radiate postoperatively. And whether or not you give chemo postoperatively is not very well teased out. So you're probably not going to be asked about that, but just so you know, it's a little bit of a gray zone. Some people are going to say, yes, absolutely, always give chemo. And other people are going to say, well, how did you feel the resection went? There's only one situation where postoperative radiation or chemotherapy may be indicated, and that is if you have what's called a drop met. So you're going to see these pockets of disease around the chest cavity, and therefore, it's more advanced, and chemotherapy is definitely going to be recommended. But most of the time, those drop mets can be seen on a preoperative CT scan. But occasionally you encounter them intraoperatively, and then in that situation you would recommend postoperative chemo. So don't worry about the stage. The stage doesn't really affect thymomas so much. Thymomas, lymphomas. If you have a diagnosis of lymphoma up front, it's always going to be chemotherapy. So the role for the thoracic surgeon in lymphoma is mostly diagnostic. The only exception to that is when for instance, I had a woman a couple of months ago that had a large hilar lymph node. I mean, it was large. It was like 4 centimeters, big, gigantic lymph node. Biopsying it didn't really make much sense. So I just took the whole thing out, and it turned out to be lymphoma. So I treated her surgically. But there really is almost no role otherwise for treating lymphoma with surgery. It's just a diagnostic position that you take as a thoracic surgeon for lymphomas. Teratomas, this is important. Okay, so if you have a patient that's presenting with a teratoma, you need to check their beta-HCG and their AFP. They're going to be elevated. Patients are going to get 4 cycles of chemotherapy, and then you're going to check those numbers again. If they're still elevated, they're going to get another 4 cycles. If they're not elevated, you're going to get a CAT scan. If the CAT scan is whistle clean and their markers are completely normalized, those patients are observed. If their cancer shows a remaining amount of abnormal tissue, you're going to go in and explore them and resect all the remaining abnormal tissue, even in the face of normalized markers. If the markers are abnormal and there's no residual tumor left on the CAT scan, that's a gray zone. People don't know what to do with that patient. Some people explore them, some people just watch them, repeat the markers. This is after 2 cycles. Remember, the first cycle is 4 cycles of chemo. And now you've repeated and the AFPs are still elevated, you're going to give 4 more cycles. Now let's say the tumor's gone, but they're elevated still. We don't know what to do with that patient. If the markers are still elevated and there's still tumor there, that's easy. You just go back in, you go in, and you resect everything that you can find. Okay, so this disease is driven by these markers as to what we do. That's thymoma, that's lymphoma, that's thyroid tumors. Thyroid tumors, papillary thyroid tumors, can commonly go into the long end of the mediastinum. Surgical resection is indicated for anybody who has good control over their primary tumor, which is usually the case. The only other time thyroid tumors are important in the chest is when you have an anaplastic thyroid tumor, which may need some resection of the manubrium in order to access the rest of the tumor, or in the case of a very large substernal goiter, where partial manubrectomy may be necessary in order to safely access the inferior blood supply that's coming and feeding the large tumor or the large goiter. Generally speaking, you can pull the goiter up, but it can often be very difficult to manage the blood supply if it's a little bigger on that distal side. So that's the indication for more aggressive, manubrectomy or partial sternectomy for patients with thyroid goiters. Okay, so now we're going to move on to pearls. Remember to either do a PET or a mediastinoscopy or both. So the patient's mediastinum has to be evaluated before you can determine what treatment you're going to do for lung cancer. So whether you take the East Coast approach at doing mediastinoscopy on everybody or the MD Anderson approach of doing a PET scan is up to you. On the exam, it's controversial. You're not likely to get it, but you have to evaluate the mediastinum one way or the other. And if you get a PET that's positive in the mediastinum, all of those patients need mediastinoscopy to confirm the PET positivity, to see what that is. You may consider giving neoadjuvant therapy in the face of stage 2 disease if you know ahead of time that those hilar lymph nodes are positive, okay? But that is only in the rare circumstance that for some reason you've been able to access those hilar lymph nodes. That can be very difficult. But if they give you the answer already, okay, those patients with hilar lymph nodes that are positive, they can be given neoadjuvant chemotherapy and treated almost like a stage 3 patient. Remember, but otherwise, if you're stage 3, right, once you know that those mediastinal lymph nodes are positive, for sure, you're going to go ahead and give neoadjuvant chemotherapy. And then we talked about that, the stage 3 with those N2 lymph nodes. Remember never to operate on a patient with a malignant pleural effusion. You may not know that that effusion is positive, so make sure if you're getting a question with a cancer and a pleural effusion, the first thing is diagnose that effusion. If it's positive, surgery's out. N2 disease is that stage 3. Make sure you're giving neoadjuvant chemo or chemoradiotherapy to patients with N2 disease. Doesn't matter which one, you're not likely to be asked. It's going to be one or the other. Never radiation alone. It's always going to be either chemo or chemoradiotherapy. T3, so we know T1A, right? That's 3 centimeters or less. T3 are things that you can take out. They are operable patients. You can take out another lobe. You can take out the pericardium. You can take out the diaphragm. You can take out the chest wall, okay? You cannot take out the heart. Or somebody asked me, well, couldn't you reconstruct part of the right atrium? I mean, I guess you could, but I mean, this is not going to happen on the exam. So no, anything you can't take out is considered unresectable disease, T4. We didn't talk much about carcinoid because I don't think it's such an important thing for this review, but carcinoids tend to be these cherry red lesions. When you do bronchoscopy, you're not going to want to biopsy them, but I think that's probably not a likely thing you're going to encounter. We did talk about the small cell cancers. A stage 1A small cell is amenable to surgical resection with equal results to chemotherapy. You want to consider a pneumonectomy for anybody who has level 10, or these are mediastinal, these are lymph nodes that sit right at the crotch of the mediastinum and the hilum. Very hard to identify exactly if they're within or without of that mediastinal pleura. So we label them, 10s and 11s. Again, I didn't press on this because I don't think this is probably likely for this review, but it's something just to remember that pneumonectomies are based on the position of the positivity of the lymph nodes at the time of surgery. Remember, you can consider pneumothorax. If you have a spontaneous primary pneumothorax, think about whether or not you've got a bolus there. In a patient that presents with what appears to be a very large pneumothorax presentation, could be just a gigantic bullous, and so you don't want to put a chest tube in that because then that's going to be a disaster, constant gigantic air leak. So you want to think about that before you put a chest tube into that, and never put a chest tube in for a TB effusion. And I think that's it.